So if someone presents with muscle problems, we think about subacute proximal muscle weakness, right? Myopathy, there's no sensory involvement. So we know the patient's really just going to present with muscle weakness. And what are clues in the question stem and in reality when we have somebody with weakness is they have elevated markers of muscle destruction like CK and aldolase. So these are all things to give you hints about myopathies. Now, the three myopathies that are important for us to remember are dermatomyositis, polymyositis, and occlusion body myositis. Dermatomyositis, what does it also have? It's in the name, derm, skin findings, right? The heliotropic rash, the shawl sign with the rash on the neck and chest, as well as Gotrin's papules, those extends on your knuckles, those plaques. So you get the derm in dermatomyositis, you get myopathy and skin symptoms. Polymyositis, really just that proximal muscle weakness. Remember that both of these inflammatory myopathies, remember two things about them. One, you need to do a malignancy screen. These may be paraneoplastic. Dermatomyositis is more paraneoplastic than polymyositis, but you need to do a malignancy screen on these patients. And they are responsive to immunotherapy, like corticosteroids, IVIG, and steroid sparing immunosuppressants. Whereas we have our loner inclusion body myositis, or IBM, which is characteristically not just inflammation. We think about degeneration of the muscle here for inclusion body myositis. And what's important about this myositis? It's not responsive to immunotherapy. So you have a muscle disease that's responsive to immunotherapy. Is there any rash, anything? Think dermatomyositis. If there isn't, think polymyositis. If there is no response to immunotherapy, think inclusion body myositis. Now, what's important is almost hallmark of inclusion body myositis is finger flexor and knee extensor weakness. So we talked about myopathies causing, you said, hey, you just told me it's proximal weakness. What are these finger flexors? So those are distal, right, in your hands. But that's really hallmark for inclusion body myositis. With along with knee extension and this proximal weakness, you're going to see finger flexor weakness. So this is just some quick pictures. Here you can see some atrophy on biopsy of dermatomyositis over here. These are the Gotrin papules we talked about on dermatomyositis. And this we just added here because we wanted to make a point that polymyositis presents commonly with interstitial lung disease. So when I think about dermatomyositis, I think paraneoplastic cancer. Then I think polymyositis, I think interstitial lung disease. So that's kind of the associated. Always remember these muscle diseases usually have some systemic issue if we're thinking about these disease points, these two for dermatomyositis and polymyositis. So that's going to help you in those question stems too. You're going to see that weakness with some added features. And that's how it's going to help you differentiate as to what the diagnosis is.